afternoon, everyone, and welcome to Better Health Partnerships webinar on parenting at mealtime and playtime. My name is Diane Solov, and I'm pleased to welcome you to Parenting at Mealtime and Playtime, which is a collaborative of the Ohio chapter of the American Academy of Pediatrics. The program is an evidence-based approach to preventing and managing childhood obesity. Targets children ages birth to 5 to increase parental awareness of meal and playtime milestones to foster a positive meal and play environment, improve clinical evaluation and documentation of obesity-related risks, and promotes developmentally appropriate activity and diet behaviors in families. Goals for the implementation in primary care settings include improved anticipatory guidance counseling. Am I stealing your thunder here?
A little bit.
Oh, I'm sorry. I will stop talking there and just go to the part about us, I guess, just quickly acquaint you with Better Health Partnership if you don't know us. We're a nonprofit regional health improvement collaborative whose members include community health centers, health systems, employers, public health, and government agencies, allied health, and community-based organizations. Our mission is to provide a safe space for competitors to collaborate, to improve health in Northeast Ohio. We estimate that our clinical members care for 70% of adults and 85% of children in Cuyahoga County and additional children in Summit County. Better Health recently published its first report on overweight and obesity, which covered 152,000 children ages 2 through 18 who receive care in 88 primary care practices across 5 health systems. Of the 127,000 plus with a recent BMI, 33% were overweight or obese. So first, there's a couple housekeeping rules, and then we'll get started. Your computer and phones are placed on mute for the duration of the presentation. We're going to allow for time for questions at the end of Dr. Williams' presentation. If you have a question, please type your question in the question box, and we'll answer your questions during the Q&A portion of the webinar. Also importantly, you'll receive a survey at the conclusion of the program. Please take a moment to complete the survey. Your feedback is really very important to us. So now I am pleased to welcome Dr. Tara Williams, who will share share the program to ensure healthy weight for children. Dr. Williams is a general academic pediatrician. She obtained her undergraduate degree in chemistry from Carnegie Mellon University in Pittsburgh and completed her medical degree at the University of Pittsburgh. She's been in the Cleveland area. She came to the Cleveland area for her pediatric residency training at Metro, later serving as Associate Pediatric Program Director. Dr. Williams became a site co-investigator for the American Academy of Pediatricians Breastfeeding Promotion in physicians' office practices, and has been active in teaching breastfeeding medicine to medical students, family practice, and pediatric residents for over a decade. She currently is on staff at the Cleveland Clinic and chairs her department's breastfeeding clinical effectiveness team, clinical effectiveness team, where she plays a major role in training and development of breastfeeding champions across pediatric offices. Tara, welcome.
Thank you for the kind introduction, Cindy, and thank you for those of us who are joining the webinar today. Just by way of introduction, in addition to being a general academic pediatrician with the Cleveland Clinic, I am a mother of 5. My children range in ages from 23 to 7, and I participated in the first wave of this collaborative that the Ohio AAP offered, and not only was I able to learn a lot and implement it in my practice setting, but also with my now 7-year-old son. So I have no financial or non-financial conflicts of interest to disclose. So just reviewing sort of the global aims of the Parenting at Mealtime and Playtime Learning Collaborative. The target age for the collaborative were kids from birth to 5 years. The Ohio AAP, working along with their support partners, created a series of educational handouts that we could use to augment our anticipatory guidance that help to shape parental awareness of meal and playtime milestones and really foster a positive environment around mealtime and playtime. We wanted to improve how clinicians evaluate a documented obesity-related health risk and really promote developmentally appropriate healthy activity and diet behaviors in families with the ultimate goal of changing healthcare systems and practice. So the goals for implementation were to enhance how we as providers provide interest-free guidance counseling and how we do risk assessment at well child care visits from birth to 5 years. We wanted to empower healthcare providers with tools that really helps us to build and promote foundational practices of good nutrition and activity habits. We wanted to encourage the practice of using motivational interviewing. And for those who may not be familiar with motivational interviewing, it's really a patient-centered style of communication that gets at having the patient identify their own values as the motivation for change, as opposed to the sort of the traditional way that many of us trained in medicine, which was we were the experts. You know, I have the information, I'm going to share it with you and basically advise you on what to do and hope that you do it. For those of us who've been practicing for a while, we know that practice usually isn't very successful. We also wanted to support obesity management within the primary care setting. So how did this program develop? Well, it really came about because pediatricians identified this as a need. We know that childhood obesity, as Cindy earlier mentioned, is a huge public health issue, and we as pediatricians just felt frustrated in the fact that we weren't able to successfully treat these children or address this issue in our practice. So the Ohio AAP collaborated with several partners around the state to develop really consistent and repetitious messaging that we could use to impact behavior change early in life. They combined their ounce of prevention, which was really a preventative piece looking at preventing obesity, and the pound of cure, which was more of a treatment piece, and they combined both of those collaboratives to create the Parenting at Mealtime and Playtime collaborative, which initially was a 6-month learning collaborative. It was funded by the Ohio Department of Health and the Children's Health Insurance Program Reauthorization Act, which was stably funded at that time. They created Pmp materials, and through the process of continuous feedback, have made improvements through each cycle of the program. So this approach to weight management was really unique because we're targeting the 0 to 5 age group. And the point is that we are promoting behaviors early in life to prevent what we see on the right side of the screen, which are obese children who are already dealing with comorbidities related to that obesity. So in 2007, the Expert Committee on Childhood Obesity published some management guidelines regarding management of childhood obesity. And you can see there, the pyramid on the screen shows sort of the stepwise approach that they recommend. In stage 1, primary care providers provide interest-free guidance around healthy lifestyle behaviors, regardless of the child's weight status. So this is just our routine messaging that we provide at well child visits. Given the fact that PCPs have frequent access to families with young children, this is really an ideal opportunity to address the initiation of healthy diet and activity behaviors. PCPs already provide these messages during routine interest-free guidance at well child checkups, and these lay the foundation for counseling messages. But as we move from prevention, we need to equip providers with the tools and skills to manage excess weight. We know that the evidence-based diet and activity behaviors that have been shown to be effective in preventing obesity are really the same that have been identified as being effective in treating it. So in other words, there are a limited number of high-risk behaviors that are at the center of the obesity problem for children. However, when preventative steps fail, PCPs require a model to approach incremental behavioral counseling with overweight children and their families. Should a provider identify a child with excess weight or on the trajectory to rapidly gaining excess weight, they can also begin counseling the child and family about these same behaviors over the course of several office visits, and this is stage 2 counseling. Then, if the child needs additional support, there are 2 additional levels of counseling. You can see stage 3, and then stage 4 would be the very top of the green part of the pyramid. Stage 3 is a more intense weight management program, and finally there's tertiary care support. In the tertiary care support, there's a multidisciplinary team that works with the child and the family to address behavior modification. This team is usually comprised of a physician, a dietitian, a recreational therapist, a psychologist, and sometimes a bariatric surgeon. An average of about 600 overweight and obese children present to the primary care setting each month. Tertiary care alone cannot manage a population of this size. So as such, primary care providers need to be equipped to handle childhood obesity within their environment. We know this is a very difficult and challenging task given the difficulty in packaging the work done in tertiary care with a multidisciplinary team and translating that into the primary care setting where there may only be one provider working with the family. The Ohio AAP chose to work with primary care providers because they are one of the healthcare providers with the most frequent and regular access to families with children at risk for excess weight. However, before we could expect families to change their behaviors, we needed to work with providers to change how we approach weight management practices and behaviors to develop really a standard of care. Any questions? Well, we're going to save questions for the Q&A at the end. So I don't think any of us would deny that early risk assessment is important. We know that weight fate can be set by the age of 5 years. And again, just based on practice, we know that it can be really frustrating trying to deal with helping a family of a child that's already obese. And so our best bang for our buck is really to prevent the child from becoming obese. And in the Institute of Medicine report in 2011, they state that prevention is possible and crucial during early childhood. The Expert Committee on Childhood Obesity recommends that it is essential to track weight for length, the BMI trajectory, blood pressure for kids over the age of 3, and also to assess family risk coupled with preventative anticipatory guidance. One of the tools that the Ohio AAP developed as part of this collaborative were these very nice patient educational handouts. The handouts were gauged toward the developmental milestones within an age range, and you'll see here an example of the newborn to 4-month handout. The handouts were divided by newborn to 4 months, 4 months to 6 months, 6 to 9, 9 to 12, 12 to 24, and then separate handouts for the 2, 3, 4, and 5-year well-child visit. They were arranged pretty much with the same topic headings, so starting with parent tips, and you can see it encourages the parent to keep eye contact, talk, use facial expressions. So already at a very early stage, encouraging parents to encourage using the baby's 5 senses as part of the feeding process. We know that human milk feeding is essential and important for human babies, and one of the first steps to preventing childhood obesity is to increase our breastfeeding rates. So we, of course, encourage exclusive human milk feeding for the first 6 months of life as recommended by the AAP, the CDC, and the World Health Organization. At the time that I participated in Collaborative, we did not have a separate breastfeeding handout, but one does exist, and I apologize that I don't have a copy to share with you, but it's a really nice handout that promotes and encourages breastfeeding for the moms in your practice that do choose to breastfeed. You can see that, again, it talks about activity for the baby, promotes safe sleep. So you can see a nice picture that illustrates the ABCs of safe sleep, alone on your back in your crib. On the back of the handout, it encourages you to notice things about your baby and watch your baby, and then talks about things that you can do to have fun at mealtime and encourages play and things to try and things to look out for that are coming next. This is an example of a handout for an older child, so the 4-year visit. I love that it highlights never bribe, comfort, or reward your child with food. And in the feeding advice, serve your preschooler the same food as the rest of the family. Don't fix them separate food. And so these are things that you can use to highlight when you're giving interstory guidance. Again, encouraging activity, the importance of sleep, and having a regular sleep routine is emphasized on each of the handouts. And again, things to watch for with your child, having fun at mealtime, encouraging play. We know that many kids today aren't out at the park playing. They're inside playing video games or watching screens, so really encouraging big muscle movement, and then fine motor skills using encouraging things like cutting with scissors and doing crafts, and again, giving the family fun ideas of things to try. And there is a link or a where to go for info with a link to the Ounce of Prevention website at the back of each handout as well. New last year was the addition of the Transitions to Solids handout, and this is one of my favorites. Some of you may be familiar with the term baby-led weaning. And we know this is a huge cultural cultural shift for us here in the United States. This handout really highlights, and I generally give this handout at the 4-month visit and start to talk to families about what are the developmental signs and cues that a baby will be ready for transitioning to solids. Really, the baby needs to be able to sit without support, grab things, and guide the things to their mouth. So at 4 months, I start to talk about when will you know that your baby's ready to transition, and generally the kids aren't developmentally ready till they're about 5 to 6 months. As you know, the AAP, CDC, and World Health Organization recommend exclusive breastfeeding to 6 months, so the general guideline is that we don't introduce solids until 6 months. At the 6-month visit, I will start to talk about what you can introduce to the baby, and the handout does a nice job of, talking about soft cooked vegetables, ripe, soft, fresh fruit. Ground beef is a great source of iron, crushed beans as well. A big concern that many families have is, what about my baby choking? So it's explaining to them the difference between what choking looks like as opposed to a normal gag reflex, and the fact that when you first introduce solids, a baby is going to gag. That's normal and natural. So this handout I use very regularly. Well, I use all of them, but this is, again, one of my favorites, and I love using it to teach families about baby-led weaning. For many years in our culture, families have sort of been marketed to and led to believe that they have to feed their baby, brand name, pureed foods. And so this can be challenging for families to think about how they feed their infants differently. For families that come from cultures where feeding, the family's food at the age of 6 months is normal, it's not as big of a leap. But for our families that have been feeding brand name pureed food for years, it can be a challenge to say, yeah, it's okay to feed your baby regular food. The other new aspect they developed was the Pmp Mobile App. This is a nice app that families can download from the App Store or go to the website and access it, and it has wonderful similar messaging and information, and but it does allow for videos where they can watch videos on feeding, play, nutrition, and more information. And I encourage each of you to check it out and to recommend it to your families. As part of the collaborative, we were given incentives for our patients. This was a really nice tool to have in the office. Our favorite was the My Plate. It really shows families how colorful your plate should look and what a portion size for a toddler should look like. We had pedometers for the older children, and then jump ropes to encourage indoor activities when it's cold outside. For the participating docs, I don't know if this was true for all the collaborators, but the one that I participated in, we got the book, It's Not About the Broccoli by Dinah Rose, and I have to say this really revolutionized the way I thought about nutrition. And Dinah is a sociologist, and her own mother was morbidly obese, and she shares about how she developed her interest in looking at food from the standpoint of habits as opposed to nutrients. And she talks about 3 habits that are really essential for teaching kids for developing a lifetime of healthy eating. The first habit would be proportion. So we want most of the proportion of what we feed children to be healthy, we call it fun-growing foods as opposed to healthy versus unhealthy. So, mostly natural fresh foods and the occasional fun foods like butter-free popcorn, and then rarely the sweet treats like ice cream and cake and your junk food. The second habit is the habit of variety, so making sure that you're not serving the same food for at least 3 days in a row and offering variety to your child. And talking about the fact that children, sometimes it takes 10 to 13 tastes before a child may accept a new food. That's a statement I find myself repeating over and over again during visits. It's very common for toddlers to become picky around the age of 2, and so counseling families that it's normal for them to maybe like the oranges this week and then not like them next week. It doesn't mean you shouldn't continue to keep offering the oranges. And then the third habit is that of moderation, so making sure that the child is only eating during meal times and not grazing all day long, and following their hunger cues. So teaching about hunger cues is something we start at birth. We want to feed the child when the child is hungry and stop feeding the child when the child is not hungry. I teach my residents when they're counseling about feeding infants not to ever say to a parent, feed every 3 hours so many ounces. because each baby is different, and we need to feed based on hunger cues, not based on our clock. And that is a practice that we want to continue as the children grow older. So again, giving your preschooler small portion sizes and letting them ask for more if they're hungry, as opposed to putting an adult-sized portion in front of them. Just want to hop back a little bit. This is a great resource, and I do encourage anyone who cares for children to purchase this book and read it. And no, Dinah did not pay me to say that. One of the main goals of the PMP program was really to help providers provide intercessory guidance that supported a nurturing and positive environment around mealtime and playtime. So yes, Mom, we really want Johnny to use all 5 senses when exploring his food. It may get a little messy, but that's okay. We want Johnny to explore and play with his food. Our main targets were really to counsel families about how they dialogue with their children at mealtime and playtime, and again, change how we dialogue with families around that issue, and align our counseling with age-appropriate developmental milestones so that we are promoting dietary habits and activities that lead to healthy weight. And all of this is linked to the parent-child engagement during early brain and social-emotional skill development. We never want to forget the crucial role of play. Again, this is something I think we sort of lost in our electronic world, but we know that play is essential to the development of social skills, emotional intelligence, cognitive development. It keeps kids physical, gets them out there, gets them active using their large muscles and their small muscles, encourages their creativity, and, of course, their communication. So we really want to talk about encouraging play, not necessarily exercise, but play, because play is exercise for kids. And again, the focus is really on lifelong nutrition habits, not weight. And I'll share the story of a 15-month-old that I saw in my office yesterday. I precept residents every Tuesday and Thursday for their pediatric continuity clinic, and my resident was presenting a 15-month-old who came in for a routine well-child check. The kid was growing and developing fine, and as he was wrapping up his presentation, I opened up the electronic medical record to highlight the child's weight for age percentile growth chart. And when you looked at the chart, you could see that pretty much from birth until about 9 months of age, the child had been tracking around the 20th to 25th percentile. And at the 12th-month visit, the child had jumped up 1 percentile point. And then at this 15-month visit, the child was now approaching the 80th percentile point. And so I was able to highlight to the resident that while 80th percentile would be considered normal, if you looked at the trend of this child's growth chart, you can see that this child was clearly taking in more calories than the child needed to grow, and that was corroborated by the weight for length height as well, because it's important to look at weight for length. The child's height did not go up concordantly with her weight, and so she was gaining more weight than she needed to. So we were able to, took the resident with me back into the room, and we were able to, with getting a little more history from the family, we were able to identify that this family was using food for comfort. And in fact, it was great because Mom had brought a bottle, this is a 15-month-old now, a bottle of whole milk to the office. And when I said to her, why do we have this bottle of whole milk? She said, well, because she's getting her shots today. And so her plan was as soon as this baby girl got her shot, she was going to give her the bottle of milk, to comfort her from her pain and suffering after getting her shots. And so we were able to really help Mom and Dad think about, well, what message is that sending, and what kind of nutritional habits are we promoting by, having her think of drinking from the bottle as a form of comfort. And we talked about maybe using alternate methods of comfort, such as a stuffed animal or a hug and a kiss. And so this really highlights how we change our focus from the weight and the nutrition. I could say, well, Mom, bottles are bad and you shouldn't give a bottle and it's going to rot your kid's teeth. But rather using a more patient-centered approach, sort of using a little bit of motivational interviewing, help them to identify that the value was that they wanted to provide comfort to their child. They were using food to do this, and why that may not be a good idea. And so it was cool to see the parents' light bulb go on, to see my resident kind of get it. And we'll see what her weight trajectory looks like at her 18-month checkup in 3 months. As part of the collaborative, the Ohio AAP did provide educational additional education on the theoretical model that we use for improvement, so the 3 questions that you see there on the screen, as well as the PDSA, or the Plan, Do, Study, Act cycle. And you can see it's a continuous cycle that never ends, but it's an evolving process with incremental change. You set goals. We constantly reevaluate things on a monthly basis. We determine the best process for meeting our goals, within each practice where we were and where we wanted to be. And through that continuous improvement cycle, we were able to make improvements in each of our practice sites, and as well the Ohio AAP has made improvements to the collaborative. All of this was done through data entry. When I was part of the collaborative, we did our own data entry as part of the feedback and improvement process. This is now done by the AAP staff, which I think is very beneficial for busy healthcare providers. We had monthly action period calls where we would share our successes, share our frustrations, and some of our barriers to reaching our goals. And usually there was an educational part. For example, the webinar we had with Dinah Rose, where she shared about her research that ultimately developed into her book, It's Not About the Broccoli. The AAP staff would come and do site visits with us. They'd bring us incentives. I showed you some of the incentives that we were able to give patients, as well as some of the incentives for the docs. And obviously continuous feedback. We had support from the Ohio AAP staff and the PMP project team. And then looking at outcomes, as of April 2017, all the pediatricians who enrolled in the first 3 waves of this collaborative have increased their assessment of patients' weight status by 98% after participating in the program. I think that's a remarkable outcome. We also were able to document that nutrition counseling increased by 36% and physical activity counseling increased by 54%. The Ohio AAP had hoped to get some outcomes in terms of changes in parental behavior, but that proved challenging, and I'm sure they're still looking at ways that we can do that. But I would say, if we as providers are changing our practice, I think it's safe to assume that our patients are responding to that change and hopefully making changes in their behavior. I have to say, just anecdotally from my own practice, I've definitely seen an improvement in how parents approach nutrition using this model as opposed to, again, the old model of, you really shouldn't be giving Sally juice in a bottle at night. The PMP's Quality Improvement Program has worked with over 195 doctors, residents, and nurse practitioners who have cared for over 128,000 children, 45% of which receive Medicaid. In 2017, they were able to add Spanish and Somali translations of the new Breastfeeding and Transition to Solids handouts. I will say that all the Well-Track Care handouts were at the time when I was enrolled available in English and Spanish, which was really nice for my practice because we have a large Spanish-speaking population. And they've updated several of the other handouts to be translated into Spanish and Somali, and these are available on the PMP website. New for this year, they're going to be outreaching to home visitors and community health workers. They're doing pilot trainings with the Ohio hubs, and they're planning to release 4 new handouts, including picky eating and food security, and I'm looking forward to seeing those new handouts. For more information or if you desire to join the next wave of the Learning Collaborative, I encourage you to contact Renee Dickman, who is the program manager at the Ohio AAP, and her email is listed there. And I believe Renee was going to try to join the call today as well. So that's that. Thank you, and I'm happy to take any questions. Oh, you guys can go ahead and write in your questions. Are they able to call in? No.
Pardon?
Okay, you just have to type in your questions on the...
Okay, we have a question here that has come in. How is AAP working with early care providers or other community-based wellness initiatives to further collaboration across stakeholder silos for a united effort?
That's a great question, and I'll just, again, highlight in that slide that this year they're looking to work with the community home, with the home visitors, so Help Me Grow, other early provider programs across the state of Ohio, and community health workers. They're doing pilot trainings with the Ohio hubs. And I think as we expand the program, right now I know we've had providers from the Columbus area and the Cleveland area. And I don't know if Renee is not able to call in, or Renee, if you could type in to maybe say what other regional sites have been represented. But I know one of the goals is to really make our messaging the same and how we approach this problem the same across the state of Ohio.
Great. Thank you. And there's another question that came in.
How do you respond to parents who believe their child will outgrow obesity? Well, that's a tough one. And, I mean, I always share with parents, I say to them, you know, what's great about being a kid is you can grow into your weight. So, in effect, depending on the age of the child, they can sort of outgrow their obesity. But we talk about the fact that an obese child is at risk for becoming an obese teenager, is at risk for becoming an obese adult, and what that might mean for health outcomes later in life. So it's just an ongoing conversation that you have. I think having the other benefit of doing this program within the medical home with the primary care provider is that you already have an established relationship, and parents tend to respond better to someone that they trust, that they know cares about their child, someone that they've been seeing for all the visits. And so they really are more likely to trust your advice as opposed to just some random person walking in and telling them, oh, your kid's obese and you need to change what you're feeding your kid.
Thank you. So we've unmuted the sound so that Renee Dickman can type in here.
I thought I heard a beep on my end. So hi, everyone. My name is Renee Dickman. As Dr. Williams mentioned, I am the program manager for the Parenting, Mealtime and Playtime program. And I very much appreciate your question about how we're working with stakeholders across the state. We are, as Dr. Williams mentioned, working with home visitors and community health workers this year. That started with a pilot program earlier in 2017, and we have now expanded, and we are doing regional trainings for home visitors across the state, really hoping to get that unified message from physicians to home visitors and community health workers who go into the home, meet with families, set goals around their health and wellness or lifestyle in some way. And so we have been meeting with home visitors. We're getting feedback on what kind of handouts they're providing. We've gotten feedback that they do get a lot of questions about breastfeeding or picky eating, and so we provide them the resources, and then they often encourage them to follow up with their primary care provider. So we've been doing that. And we are continuing to get the word out across the state. We've got a lot of engagement from physicians along kind of the 3 large cities in Ohio and really working. We have a great population of folks in Cleveland and the Cleveland area, so we encourage you to join a wave if that's something you're interested in doing. But we also do have folks in more rural communities, and we continue to focus our recruitment efforts in those areas as well, seeing the need there. And just one point of clarification, we do have physicians do their own chart reviews, but we have reduced the amount of chart reviews that are required in order to receive the maintenance of certification credit. So we have really heard the feedback that folks have provided in previous waves, and we continue to improve the process to make it as streamlined as possible.
Thanks for that clarification, Renee. And for those who are physicians who are listening, thanks for bringing up that point. You do get maintenance of certification for participating in this quality collaborative. So
thank you. So our next, thank you so much, Renee, for letting us know that you had good information to add. So the next question, does Parenting at Mealtime and Playtime plan to include handouts in additional language in the future? Specifically, the question is about Arabic and Swahili.
Renee, I may turf that one to you, but I will say that I guess it would depend on demand. If we had a large demand and someone who could do the translation, I'm sure they'd be open to it.
Absolutely. So I will. We are continually getting feedback from folks about which populations they're getting questions from and what languages would be helpful, and it's definitely something we're interested in doing, and I think we're going to do it based on demographic and need. So we are very interested in continuing to expand our resources to reach new populations, and So I think that's something we'll always kind of be on the lookout for.
Thank you. And here's another question for you. How do you handle a family where they cook separately for certain meals, for instance, fish, with the issue of concerns that your child will be hungry?
That's a great question. We see that in the office regularly. I'll share the example of a family I had. It was, I believe the child was 5, and mom would prepare dinner for the family, and then the 5-year-old would get a separate meal that mom prepared, and she was allowed to go into her bedroom and eat her meal while she, watched TV or did whatever, while the rest of the family sat at the table and ate, because mom was so concerned that if she didn't eat, she refused to eat what mom cooks, and so she would go hungry and obviously, starve to death. So that was a great opportunity to, have a discussion with mom about helping mom to really identify that she was, rewarding this child's behavior by essentially allowing her to make more work for mom and go into her room and, sit in front of the TV while she ate. And so we talked about the fact that, she wouldn't starve if she didn't eat, and that hunger actually is a really great driver of appetite. And so we talked to mom about, maybe including some of this picky eater's choices in the meal that she prepared for everyone, but certainly making it a ground rule that everyone sits at the table and eats together, and we eat what is served at the table. And if she chose not to eat her meal at that time, she doesn't get a substitute. She can come back to it later if she wants. Mom would just wrap it up and keep it or put it in the fridge, and she can microwave it. And if she decided to go to bed hungry, that would be fine. I'm sure tomorrow she will eat her dinner. And that can be hard, but it's necessary for behavior change.
Thank you. And here's another question.
Quickly add to that. So we do, as Dr. Williams mentioned, we do have a picky eating handout coming out for families. We're also working on something we're calling really around routine setting and setting routines and having a positive family food environment. And so that is also something that we're currently working on. I'm not quite sure of the release date, but that is something I think we've heard echoed from physicians that they're getting questions about that kind of thing. So we hope to have a handout on that as well.
And all these are available on your website, is that correct, Renee?
They are, yeah. So anyone interested is welcome to contact me, of course. And then if you just go to ohioaap.org, if you look for the obesity prevention, you'll see the PMP. It'll pop up as a sidebar. You click that, and there's a whole thing for physician resources.
Thank you. So another question just came in. We heard recently that 4 NHLBI-funded trials on preventing and managing childhood obesity were not successful in improving or mitigating weight. In order to best focus our efforts in the future, is there a way to follow patient outcomes in the future?
That's a great question, and I think we definitely have to find a way to do that. And I'm not familiar with what strategies they used in those particular studies in terms of prevention.
I don't think it was...
was it prevention or treatment?
It was both, but it was, I think, for older children, if I'm recalling.
Yeah,
it wasn't for the early childhood.
Right. So I think really we have to start targeting the birth to 5-year age group, again, to mitigate behaviors around nutrition and activity. So it's really the behaviors that we want to target, the nutritional habits, as opposed to the weight itself. Because I think when we focus on the weight or the nutrients, we really miss the point, and we're not getting at people where their values are. Again, giving the example of the 15-month-old, that the value for that family was making sure their child was comfortable. For the mom that's cooking a separate dinner for the 5-year-old, she wanted to make sure her kid wasn't going to starve to death. So I had to reassure her that her kid was not going to starve to death and that was going to be okay. And by the way, that mom was successful in getting that kid to sit at the table and slowly start joining the family for meals and having family mealtime, which is super important and something that's missing in our culture today. But the establishment of routines is critical for so many things. We know that even if we look at early literacy promotion, families who have routines are much more likely to read to their children as opposed to families where the kid has a different schedule and something different is going on every day. Same thing applies to mealtime. If we have a regular breakfast, snack, lunch, snack, dinner time, the kids are much more likely to be getting mostly, fresh fruits, fresh vegetables, and home-cooked meals as opposed to McDonald's chicken nuggets and fries on the go.
Thank you. So the previous questioner added a couple of notes here online. The two of the studies that we mentioned of the 4 NHLBI funded work were prevention in early childhood, not yet published though, and then the question, another additional question was, are you expanding efforts to include 5 to 10-year-olds, or is it limited to the 0 to 5?
I'm going to turf that one to you, Renee. I don't believe there are any efforts to expand it to 5 to 10-year-olds. I mean, we certainly, I certainly use the same counseling I've learned to do with the 0 to 5-year-olds with the 5 to 10-year-olds, but I don't know necessarily that the Learning Collaborative is going to focus on that age group.
Yeah, that's a great question. So we do emphasize the intervention with motivational interviewing and that sort of thing within the population from birth to 5. However, as Dr. Williams mentioned, the program's evolved over the last 10 years. It really started, it's kind of the culmination of 2 previous programs, and then we've updated with new material. And the previous program does have resources related to children from ages 6 to 18, and we've kept all those materials and keep them updated as the literature evolves. And so as a person in the KETA program and going through our online resources, you'll see resources related to children in the older age groups.
Thank you. Here's another question. I see a lot of parents giving their baby who's organic squeezed baby foods, these are organic squeezed baby foods, instead of using a spoon. Could, quote, drinking your food contribute to obesity?
That's a very interesting question, and I don't know that we have the answer, but I know that certainly feeding, how we feed our baby, again, the habits of how we feed our children contributes to their nutritional habits later in life. And so if the kid goes around thinking that I get all my foods from a squeeze bag, then they're kind of learning that this is how and what I eat. So it gets away from, again, fresh, home-prepared meals. So we definitely don't want to make it a habit to feed children continuously from squeeze bags. An occasional use, I guess, when you're on the run for convenience is fine. But yes, again, that gets to the whole habit issue, and we really want to counsel families to, again, that proportion. Most of what your child is eating in a day should be freshly prepared, natural foods, not something in a box or a bag or a pouch. And no matter if it says organic, it doesn't make it any better.
Thank you. And I think we've got time for one quick answer to a last question. Do you see a benefit of connecting parents who are obese with a nutritionist?
This is definitely a family issue. So as much as we want to, certainly as pediatricians, our focus tends to be on the child, but we definitely have to look at whole family habits around food. So a lot of times we refer or encourage our families to see a nutritionist. For whatever reasons, there may be barriers to that. Some families are open to it, and I think it's great. Some families are not. And so I do a lot of nutrition counseling as part of my routine well-child checkups. And many times if a parent has diabetes or has a comorbidity related to their own obesity, they are much more likely to be motivated to be engaged because they don't want their child to end up in that same scenario. So I use that as a value, and we work on goals. A lot of times we'll set small goals, one activity goal, one nutrition goal, and we work on that goal for the month, and we come back and we check in. We check your blood pressure, your weight, whatever's appropriate. And these are for the older kids, obviously, I'm targeting, and we'll follow up monthly. I had one teenager. He did amazing. He was obese, and he cut out pop, just made some small changes, and he is in a healthy weight when he's developed good habits of eating mostly fresh stuff, drinking water, and exercising, and he's actually motivated his mom, who's overweight, and the rest of the family to come on board. So sometimes it can work the opposite way too, where the child, an older child or even a younger child, could motivate their parents to make behavior change. But behavior change is hard.
Well, on that note, I would like to thank Dr. Tara Williams for leading us through this very important presentation. Gave us lots to think about and certainly a lot of resources that we can tap. We have the screen up on how to contact Program Manager Renee Dickman for some of the materials that were presented here today, and we will encourage you all to please take a moment to fill out the survey that will automatically come up on your screen as we exit the webinar. Thank you again for attending, and we hope to see you at our next one.